Hello. Let's go ahead and get started. Enjoy your lunch. Thank you all for taking the time to come to this conference or this symposium. We have a pretty tight schedule today with just an hour to try and get through 4 speakers. Your panel today is Dr. Kevin Ives, Dr. Paulo Tagliabue, Dr. Amir Kugelman, and my name is Mike McQueen. The format for today is to actually look at some practical applications in the NICU of high-flow therapy. We've had a pretty enlightened morning, all of us, listening to Dr. Yoder and others do some fantastic presentations on the potential benefits of high flow, and we're all clearly just getting our feet on the ground to do this. Our agenda is that you will hear brief data presentations from the 4 speakers. After that, we will do the questions, so if you would do us the courtesy of holding your questions until the end of the session, that will guarantee that we can at least get all the speakers through their presentation. Vapotherm will send out follow-up information for you on your request. There are comment cards included in the packets at your seats. If you would do us the honor of filling out those cards, we will follow you information that you request, and feel free to write any comments about the symposium format or the information on the back of the cards. Online versions of this material will be distributed. Again, my name is Dr. McQueen. I work at I'm a community neonatologist in private practice. I work at 3 NICUs in the West Valley of Phoenix, Arizona. I'm not affiliated with a university, and we're hoping that perspective from in the trenches, so to speak, is of some value today. I can tell you that I had the privilege of doing my neonatal fellowship at the University of Vermont with Dr. Lucy and Dr. Horbar and Dr. Saul, so I would like to think I do know the difference between a randomized trial and anecdotal evidence. I will also tell you that when Dr. Lucy and Horbar and Saul recruited me, they showed me Lake Champlain and the sailboats and the Ben & Jerry's store, and as the day that I signed my contract to be a fellow at Vermont, they gave me a medical statistics book. So I am familiar with the randomized trials and the importance of us proceeding in that manner. All of the speakers do have consulting agreements and have been supported by Vapotherm to come and participate in this conference. Well, as you heard people speak about this morning, there's been a lot of confusion perhaps and misinformation about high-flow nasal therapy. And I think Dr. Yoder did everybody a great service by emphasizing the humidified and heated high-flow nasal therapy. Some of us who've been using Vapotherm or the other devices for a while have taken that for granted. But it is a given that when we talk about high-flow nasal therapy, we are talking about warmed and humidified. What I have heard from my colleagues as I have traveled around and even in my own community is, well, who is using this? Where's the evidence? Where's the data? How is it different than nasal cannula? How is it different than nasal CPAP? And probably the most pressing question, largely now preempted, I think, by this morning's talks, is I'm not going to use it. You don't know how much pressure you're giving, and it's dangerous. I think there's 2 hopes I have for the end of this symposium. Is one, that the danger concerns have been largely alleviated. No matter which speaker, which high-flow device, or which study design was used, you saw that there just was no increased incidence in pneumothorax. And at the end of the day, I think it's fairly safe to say that the pressure mechanism, the pressure delivery mechanism, can be on the back burner in the high-flow nasal cannula discussions. I think the primary mechanisms are, in fact, what Dr. Yoder referred to as insufflation, the anatomic dead space washout, the washout of the end expiratory CO2, so that the first breath in that the infant takes is not preloaded with CO2 from his previous exhalation. The nasopharynx and oropharynx, as you can see in the cutout, are in fact a disproportionately large piece of the anatomic dead space in the infant respiratory system, and making high-flow nasal therapy, and particularly the washout mechanism, particularly amenable to this patient population. The 3 NICUs that you're going to see some data for are different levels. One is an 8-bed level 2. One is actually a 16-bed level 3A in the AAP categorization. It's what's known as a 2E in Arizona. And we have a third nursery, a level 3 nursery. The 3 centers combined have an average delivery base of about 11,000 deliveries a year. This is from just that level 3A center from Banner Estrella for 2009-2010. You can see that the numbers are small, but this is the breakdown of patients by gestational age that were enrolled in the Vermont-Oxford network. In that patient population, for all comers, the bars on the left, 95% of the babies admitted to our NICU don't need any ventilator support at all. Given that there were a fair preponderance of larger babies, that's not too surprising. What I think is more relevant for today's discussions is that the low birth weight population, again, small numbers, again, 71% of those babies did not receive any ventilation at all, 0 ventilator days. If they required surfactant, they were intubated, given their surfactant, extubated immediately to high-flow cannula. Of the babies that did require ventilation, in 2009 we had no patients who were on longer than 24 hours. And in 2010, our data was remarkably similar. 95% of all admissions required 0 ventilator support. 72% of our low birth weight babies required no ventilator support at all. We did have a couple of patients that were on the vent, and again, they were the tinier ones, 24 and 25 week babies that were on up to a week, but we had no patients that were on longer than 7 days. Someone had mentioned cost earlier in the presentation. I know that's not necessarily the focus of this academic conference, but I did want to throw in this slide since it's something that we've looked at, and I think it's going to be more relevant for all of us. Like it or not, it's going to be more relevant for all of us. This is an analysis of cost per NICU case before any fixed indirect costs are added. The fixed indirect costs team are things like your hospital's housekeeping services and your cafeteria and the heating bill. So this is the true cost of service before those indirect costs are allocated to your nursery. And you can see the trend at the Banner Estrella, the bar on the right, a significant decrease in the cost per case. I think part of it is the lack of ventilator use. Part and parcel of that lack of ventilator use is that we shoot fewer x-rays. We do fewer blood gases. We actually draw fewer labs. Because we draw fewer blood gases, we give fewer blood transfusions. We send no babies home on oxygen. Our chronic lung disease rate is very, very low, and the length of stay is shorter. It's a composite. It's not just the magic of the high-flow nasal therapy, but it's actually a commitment to that program, and the side effects kick in from there. One quick comment, and I'll turn it over to our other speakers, on using high-flow nasal cannula in a level 2 center. I heard one of the questions during one of the talks this morning was we can't get our parents to agree to be back transported to lower levels of care. You know, they've grown comfortable with us, they're comfortable with the high-flow nasal cannula, and they want them to stay in our tertiary center. Let me show you our experience, which is that with this device, you may not have to go to the tertiary center in the first place. This is from our community level 2 NICU. Again, it's small. There are about 2,000 deliveries a year there is all. And you can see over the past 5 years, we transported out anywhere from 30 to 40 babies to downtown, wherever that is in your market, the Children's Hospital, the University Center, whatever. You can see an abrupt drop-off in 2010 and almost non-existent in 2011. That correlates directly with the introduction of us using high-flow nasal therapy in 2010. Just looking at the last couple of years, it's a pretty symmetrical trade-off. In 2009, 40 babies were transported out of this level 2 unit to higher levels of care, and we had 0 vapotherm cases. In 2011, that was reversed. Only 3 babies were transported out, and we had 40-some vapotherm cases. So I think even in a level 2 NICU, you can probably have significant benefits. You can decrease the transport risk. You can decrease the transport cost. You can keep the babies at the facility where their mom's delivered and keep them there with their families. Just a couple of pictures quickly, because I wanted to touch on, again, some of the points that were so well made. Look closely at the nasal prongs in the baby's nares. I think this was, you know, maybe one of the two highlights of this. Every speaker did emphasize non-occlusive prongs. That's one of the answers to not delivering pressure with high-flow nasal therapy. There's anatomic pop-off valves. There is, in fact, room for ventilation out of the non-occluded nares. Also, you can see we don't worry about having the baby's mouth open at all. The nurses can position them any way they want. I heard multiple people comment that the nurses love it and the families love it, and it's more comfortable, and even some comments that the nasal trauma was less compared to nasal CPAP. I heartily agree with all of those, in fact, to such a point that If the clinical outcomes and efficacy are not significantly different, and yet the patient satisfaction and the nursing satisfaction and the nasal trauma is less, I'm not sure non-inferiority is exactly the right vocabulary. You do get a little bit of abdominal distension. We put OG tubes in our babies to help decrease some of the air that goes into the stomach. And feeding the babies, initiating early nutrition orally can sometimes be a bit of a challenge, and there is a learning curve involved with that. It is so comfortable and so easy to do that this is actually a 25-week baby that's about a week old now. He's 26 weeks corrected. And we hand the baby over to kangaroo care with the family. Mom sits in the rocking chair next to the baby and can hold the baby for 15 to 30 minutes at a time.